Should I start?
Yes, sir. Please.
Okay. Thank you. Thank you. Okay. So I think good evening to all the listeners. I think PG students are there and pediatricians are there and general physician. But I think these are our target for population today. So we are today discussing our approach to brain tumors in children. I'm Dr. Pankaj. I'm a senior consultant at National Cancer Institute, Nagpur. And today we see how we approach a suspected case of brain tumors. So this will be interesting actually for all residents, because I think it is a little bit quite a difficult topic. But if you go step by step, definitely you will get your answer or reach to the diagnosis. Okay, so just before starting, just revision of normal anatomy of the bone, of the brain. You know, you have a different parts of the brain. So you may, and at different part, there is a different tumor. And a little bit, I will repeatedly take the names of those fancy names. For example, ependymoma, astrocytoma, optic glioma, pinealoma, medulloblastoma, cerebellar astrocytoma, and so on, so that you will familiar with those terms, and it will not be difficult for all of us to understand the basic concept of brain tumors. Before that, I would like to go through one case. So this is Aditya, is an 8-year-old boy who has been complaining of an intermittent headache for last 2 to 3 months. And they have seen parents went to the doctor in walk-in clinic twice in the last few months, who reassured the family that everything was fine. When you ask other symptom, you discover that for the past week, he has vomited, and usually in the morning, and his parents have noticed him having troubles with the balance, bumping into the walls and furniture, which is uncharacteristic of him. He is also having a difficulty going up and down the stairs, needing to hold the handrail. You perform neurological examination, and what you find is it has some unsteady walking heel to toe, loses his balance when trying to stand on his left leg alone. The cranial nerve exam reveals horizontal diplopia and what you believe to be an abducens or sixth nerve palsy, as he has a right esotropia. The rest of the examination is unremarkable. So now you think, what is the problem with the Aditya? This is a very prototype presentation, or we will take this example to understand different aspects of the brain tumors. So with this case, our main objective of today's presentation to recognize the clinical presentation of brain tumor in children and key finding on the history, physical examination, and differential diagnosis. And we also like to delineate the epidemiology and etiology of the brain tumors in children. And we will also review the initial management and mainstay of the treatment for common types of the brain tumor in children. We will take a little bit deeper this thing, like few like choroid carcinoma. We will take those looks also. So to start with this, why it is important actually, why it is important to understand the brain tumors in children. It is the second most common childhood tumors. Other than this, acute lymphoblastic leukemia is the most common malignancy in childhood and differ from the adults in site affected, clinical presentation, and gross picture. They are not staged but graded, though it is not a completely true statement. They can also be staged, but main thing is a grade. By virtue of that, we decide the plan of treatment, and they present with a non-specific symptom, hence ignored, and diagnosis is delayed. That is why we should understand, and we should look into this matter to understand what is happening with the child. What is the difference from the adult? How they are different from the adult? So it is the second most common in adult. It's the sixth most common. 70% are infratentorial. We will understand what is infratentorial, what is a supratentorial. Overall, they having a good prognosis. Overall, not each and a specific tumor has a different prognosis, but overall it's a good prognosis as compared to other adult, where prognosis is really guarded. So just this is the revision of our anatomy classes. What brain has, though everyone knows, this is the covering is meninges, then CSF, cerebrospinal fluid, there are the ventricles, thalamus, pineal body, cerebellum. In front, you have a pituitary, pose, reticular formation, medulla oblongata. So these are few structures why we are taking the name, because with this we will actually formulate or the name of the tumor sometime derived from the site they originate. Okay, so as I discussed, what is the tentorium and how we decide that what is the infratentorium, what is the supratentorium. So if you see the tentorium, it is it is defined as actually it means a tent of the cerebellum in Latin, but it is an extension of the dura mater that separate the cerebellum from the inferior portion of the occipital lobe. So if you can see the red line, this is the red line. So what is the below is the infratentorial, and what is above is the supratentorial. So mostly the cerebrum part is involved in the supratentorium and cerebellum in an infratentorium. And why it is important? Because your clinical features is also depend where the tumor arises. Now, little bit, actually, I would like 1 minute. Okay, so now can we go back? Yes. Now, so we will see little bit of a structure of the brain, and we will revise it. That will helpful to us in understanding the details of the brain tumor. So neuron is the main cells. So neuron is the main CNS. There are supporting cells and tissues, that's like a microglia, astrocytes. There are the capillaries, ependymal cells which line the ventricles, and you can see oligodendrocytes are there, myelin are there, myelin sheaths are there. So we will understand what are their function. What an ependymal cell does, they line the spinal cord and ventricles and involved in the creating a CSF. What is the astrocyte? Though I know you all know astrocytes that started in the neurotransmitters provide supports the axons of neurons in CNS, particularly those travel long distance within the brain, produce a fatty substances myelin, which is wrapped around axon as a layer of insulation, and microglia as a brain immature cells to protect it against the injury and disease. And what is in the peripheral nervous system? Schwann cell, similar to the oligodendrocyte in the CNS. Schwann cell myelinate neurons in the PNS. Satellite cell surround the neurons in the sensory, sympathetic, parasympathetic ganglia. What is the anterglial cells? The anterglial cells are found in the nerves in the system. This background
पंकज सर, आपका माइक्रोफोन म्यूट हो गया है.
is that?
Yeah, now it is.
Can you hear me?
Yeah, now I can hear you.
Okay.
I think signal की वजह से म्यूट हो गया था.
Right. Okay. So should I repeat the last slide?
Yeah, repeat couple of 3 slides back. आपका सिग्नल बीच में वेरिएबल हो रहा था, तो प्रॉब्लम आपका स्क्रीन शेयरिंग भी बंद हो गया था.
Okay. So from here,
अभी तो स्क्रीन शेयर नहीं हो रहा है आपका, एक बार दोबारा स्क्रीन शेयर कीजिए सर।
Okay.
या इससे 2 स्लाइड पीछे सर।
Right.
या यहाँ से।
Okay. Okay. So we will discuss it again. It is very important slide actually, because most of the time we don't know what is the supratentorial, what is infratentorial. So we have to understand tentorium. It is a cerebellar tentorium. In Latin, it is called tent of the cerebellum, and it is an extension of the dura mater that separates the cerebellum from the inferior portion of the occipital lobes. So most of the time above the tentorium, it is the supratentorial cerebrum, and in below this is a cerebellum, or we call it infratentorial organs are there. Now, after that, we should know a little bit about the tissues and cells of the CNS and the PNS as well. So, you know, the neuron is the main cells supported by the microglia, astrocytes, or the capillaries, ependymal cells, which line the ventricles of the brain, and oligodendrocytes, myelinated axons, and myelin sheath that is shown in this figure. These are very important because all the origin of the tumor occurs from these cells or tissues. So ependymal cells lines the spinal cord and ventricles involved in creating CSF. We all know astrocytes are starshaped, maintain a neuron's working environment by controlling the level of neurotransmitter around the synapses. Oligodendrocytes provide supports to axons of neurons in CNS, particularly those that travel long distance within the brain, produce a fatty substance, myelin, and which is wrapped around the axons as a layer of insulation. Microglia, brain's immune cells to protect it against the injury and disease. In PNS, same Schwann cells, similar to oligodendrocytes in the CNS, Schwann cells myelinate neurons in the PNS. Satellite cells surround the neurons in the sensory, sympathetic, parasympathetic ganglia and help regulate the chemical environment. And endoglial cells, they are found in the nervous system, the digestive system, as name suggests. Okay, so before going to more details, we should understand very important concept while going through the details of a brain tumors. They are the grading. A grade because defines the treatment plan and the prognosis. So as you can easily take it out from that, like for example, grade 1, they are a slow growing, non-malignant, long survival can be expected. Grade 2, intermittent between the malignant and benign condition. Usually they are slow growing, but sometimes recur as a higher grade and can be malignant or non-malignant. Grade 3, definitely a malignant, often recur as a higher grade, and grade 4 reproduce rapidly and very aggressive. So what make them grade 1, grade 2, grade 3? It is actually a proliferations of the cells, uncontrolled proliferation of the cells. So taking into those accounts, and myograding is there, and which based on the nuclear atypia, mitosis, endothelial proliferation, and the necrosis. Though we will not go into details, but you should know the concept of grading. When pathologists write grade 1, grade 2, grade 3, grade 4, what comes in your mind? This is only to define those concepts. Okay, so as other malignancies are associated with other associated conditions or their inherited genetic syndrome, so the brain tumors are there. There are higher chances of a brain tumors in some of the conditions. So whenever you examine your patient, always sees those signs and symptoms which leads you to the probable diagnosis of the brain tumor in given context. For example, neurofibromatosis type 1, they have a higher chances of developing a gliomas. Same as with the neurofibromatosis, tuberous sclerosis, von Hippel-Lindau syndrome, Lee-Fromany, retinoblastoma gene, familial adenomatosis polyposis. And though it is very important to know that perinatal ultrasound is not associated with the brain tumors in childhood. But prior CNS radiation, yes, could be. For example, like in ALL cases, child received a cranial prophylaxis. In few years back, we used to give the CNS prophylaxis, and later on it can cause a brain tumors. Now we try to avoid this CNS radiation as much as possible. Okay, so what is the clinical presentation and how they come and how you will diagnose whether patient is developing brain tumors or not. So it depends on the site. We'll see age, aggressiveness of the tumor, effect of the tumor, and peritumoral edema of the brain, and obstructive hydrocephalus. So we'll see. Now, as we have seen, tentorium defines the supratentorium and infratentorium part. You can easily make it out. If you go through the clinical sign symptom, what could be the site of the origin of the mass lesion or pathology. So raised ICP, in 47% of the cases, raised ICT may be the features. Because of the cerebral involvement, they may have the seizures. They may have, because of the hydrocephalus or raised ICT, edema can be there, and there could be a focal neurological sign. Headache can be there, but it's not a so prominent. Hemiplegia you can find, and nausea, vomiting, and macrocephaly in infants. So that you can find out if they are the supratentorial. Just see what you will find if they are infratentorial. The nausea, vomiting is more common, and headache is more common, though headache was not so common in a if you go to the last slide. So then on a supratentorial, you can see and you can compare actually. So nausea and vomiting most common in a posterior fossa. If you see, because their cerebellum is there near the bones, you can find abnormal gait and coordination difficulties, papilledema, abnormal eye movement, lethargy, weight loss, focal motor weakness, and macrocephaly, etc. You see the brainstem. What are the brainstem findings? So same, any lesion which involves the brainstem can have abnormal gait and coordination difficulty, cranial nerve palsies, headache, squint, focal motor weakness, facial palsies, papilledema, raised ICP, and in that frequency. So if you you can delineate the site of the lesions, and you correlate with the age and the symptom, and you will. In spinal cord, backache is the most common symptom, and abnormal gait and coordination difficulties, and spinal deformities, focal motor weakness, decreased upper limb movement, developmental delay, and head tilt and headache. These are some few signs and symptoms at different sites. Now, let's go back to our case, that is Aditya. So he presented long-standing history of intermittent headache. You have seen, and more recently developed episodes of vomiting and trouble with coordination and balance. So definitely you are dealing something with the infratentorial part. He has a handful of concerning signs on examination, including cranial nerve deficit, can be a pons, can be a cerebellar increase that it is impinging on the pons. You also note that he does not have any neurocutaneous finding. So you can make a little bit of diagnosis or helpful in delineating the pathology, suggest of neurofibromatosis or tuberous sclerosis. So what you requested a head CT, which reveals a mass in the posterior fossa. Now, what are your next step? So your next step depends on definitely on the sign symptom, as well as the you want to establish the definitive diagnosis. Okay, so let's see. At this time point, you have a few differential diagnoses of the brain tumors, common condition, tension or a migraine headache or non-specific infection. Less common are the brain abscess, non-malignant hydrocephalus, intracranial hemorrhage, or a AV malformation. These are few of the differential diagnoses. Now, what you order as a diagnostic workup, these are very specific in cases of the brain tumors. MRI is one of the most important. Well, definitely you want, if you will see the serum creatinine and other renal parameter, and you can ask through them to do the with contrast, and you have also asked them to do the spectroscopy if necessary, because colon peak very much helpful in delineating whether it's a malignant or you are dealing with a benign condition, and then diffusion and perfusion scan. You can ask for the tumor marker, that is important in a germ cell tumor. You will see later on. Basic blood workup if you are planning a surgery, for example, if you are planning a biopsy or complete excision of the mass. CSF examination in few cases, even actually in most of the cases need a CSF examination, but patient come with the hydrocephalus, definitely CSF examination, or the ICT CSF examination, not the urgent thing that you want to do. And definitely neurosurgeon, your friend, will help it out for the diagnosis as well as the therapeutic. Once you make the diagnosis, then there is a multidisciplinary meeting that include a pediatric oncologist, that include your social worker, that include your neurosurgeon, that include the RT people. So actually it's a combined effort. Any malignancy is a combined effort, and it is dealt with the tumor board or such team. Uh, actually, this is not the part, not a part of a presentation, but actually, I think that this is the most important part of a management. When you tell them parents first time, then it's a very important that one who has a very much experience in this field, they should break the news with presenting the facts and definitely giving the support. So most of the time, include a member from multidisciplinary team along with the social worker. This is a little bit of introduction of brain tumors or normal physiology and normal functioning of the brain. Let's see what is the epidemiology of the brain tumors. It will help you in finding out if, for example, 6-year boy who presented with a rapid onset of a symptom, definitely there is a something, medulloblastoma is a more common rather than a low-grade glioma. So for 0 to 14 year, if you see, pilocytic astrocytoma is a more common as compared to the adolescent, where tumors of the pituitary are the more common. So this is only the frequencies of the different tumor at different age groups. Now, other than this, if you see whole gametes, 21% of tumors are a CNS tumor, including the benign and malignant tumors of the brain and spinal cord. Most occur before the age of 10 years. Male are more affected, 1.3:1, 60 to 70% have a 5-year survival. We will see one by one. Okay, so classification depend on the site, depend on the histopathology, and now most important thing is the molecular classification. So we will take one by one. Some are important, some are for actually deciding the prognosis, and some are for delineating or to tell them the treatment plan. So tumor of the neuroepithelial tissue, like a astrocytic tumor, oligodendroglial tumor, if they include oligo and both the parts, oligo, astrocytic tumor, ependymal tumors, choroid plexus tumor, embryonal, like a medulloblastoma or a PNET, tumor of the pineal region, and neural and mixed neuronal glial tumors. Tumors of cranial and paracranial nerves, tumors of meninges like meningioma, tumors of hematopoietic system. For example, CNS lymphoma is though not common in pediatric age group, but in adolescent we can find once in a while like a CNS lymphoma. And the germ cell tumor, as we have seen in adolescent, there may be the common presentation if they are having the brain tumors. Tumor of the cellular region and the metastatic. Metastatic means they are coming from somewhere else. For example, ATRT of the renal that can actually metastasize to the brain, and so on. Now the classification based on the histological frequency. This is a difficult slide, but as I said you that I told you that you should know the basic names of the actually cells, and you can easily remember those names. For example, pilocytic astrocytoma, other low-grade glioma, they all come into the gliomas, high-grade gliomas, ependymal tumors, other glioma. So based on the histopathology, they are divided into different groups. Now, as I said, some are common in a supratentorial, some are common in the infratentorial. So this classification also based on the location. For example, in supratentorial, astrocytoma low grade, they are 80 to 20%. Astrocytoma high grade, they do around 6 to 12%. Same is with the ependyma, mixed glioma, glioma, and so on and so on. Infratentorial, medulloblastoma is the most common malignant tumors, and it accounts upon the 20 to 25% of the all CNS tumors. Other than this, astrocytoma, ependymoma, brainstem glioma, high grade can be a low grade, and others. So with this background, we will come to more common as a prototype. Actually, we can't discuss each and every case, every CNS tumor, but most common and little bit about the rare tumors we will discuss in this presentation. So if you see, medulloblastoma is an embryonal tumor of the posterior fossa, most common malignant brain tumor in the children, and biphasic incidence, maybe peaks at a 3 to 4 year of age, and again at 8 to 9 year. It has a previously WHO classification that is based on the histopathology. So it is divided into a classical histology, anaplastic, desmoplastic, and medulloblastoma with extensive nodularity. At that time, actually prognosis depend on the histopathology as well. But as the time, with the time, there is a development of a molecular pathways. So there is a change in the classification. Now, how we classify them depending on the what pathway include in their pathogenesis or etiology. So for example, WNT wingless, they have a better prognosis. SHH have a better prognosis. Group 3 has a worse prognosis. Group 4 has an intermediate prognosis. So depending on that. Other than this, post-surgery also, and depending on the age, there's called a chance risk stratification, a little bit more about medulloblastoma. So if completely rejected, they having an average risk group. And if there is a residual that is more than 1.5 centimeter square, then there may be come into high risk. If histology are classic, desmoplastic, nodular, they are average risk. If they are anaplastic or a large cell, they are coming to a high risk. This based on the, if you combine all histopathology and the molecular pathway, you can group into 4 group actually. You can divide. One is called WNT, what we have gone through right now, SHH, group 3, group 4. So this picture shows you what is the prevalence of the different subtype in different age group. WNT, very good prognosis, 94. Why it is important? So that we can actually tailor our chemotherapy, radiotherapy, and surgery. Sometime WNT pathway doesn't need further chemotherapy except for the good surgery. But this is under evaluation, so it is not a definitive guidelines. But right now we treat them with the chemotherapy, surgery, chemotherapy, radiotherapy. Group 3 has a worse prognosis. Group 4 has an intermediate prognosis. And when you know the pathway, what is important? You can use the pathway and you can actually use the blockers for these pathways. For example, we have preclinical data is there for SHH pathway. So you can actually stop further proliferation of the tumor if you know where exactly you want to hit. So this figure only, or a cartoon only showing that pathway for a different this type of a medulloblastoma. Now coming to, because it's the most common, so I will go a little bit detail. If the child come to you and you diagnose as a medulloblastoma, definitely sometime it is important to take the biopsy, or sometime it is important to go for a surgery upfront. And when you find it out, what is it is a medulloblastoma, then what is the further treatment? It depends on the age, because less than 3 years we avoid RT to the growing brain. So what in less than 3 years we give first chemotherapy. There are chemosensitive tumor, and later on delayed RT can be planned. In more than 3 years, you give the craniospinal irradiation and along plus minus concomitant chemotherapy followed by adjuvant chemotherapy. So this is the treatment plan for that. Because you are not using a RT earlier in this less than 3 year age group, survival is dismal. But if you take survival in more than 3 year group, it reaches up to 70 to 80 years. Another group is a ATRT. So actually this is a very aggressive tumor, and the prognosis is very much guarded. It depends on largely on how it has been removed. So highly aggressive tumor seen in children younger than 2 years of age and frequently present as a metastatic disease at diagnosis, recently recognized as distinct tumor. And 90% ATRT has a mutation of a HSNM5 INI1 gene. And older children treated with surgery plus CSI plus high dose chemotherapy plus autologous stem cell transplant. Younger patient outcome are dismal. Pattern of failure is at primary site and suggests the role of local RT. Current recommendation include local RT to the primary tumor after few cycles of chemotherapy in younger patient. RMS-like protocol, rhabdomyosarcoma-like protocol is indicated, and intrathecal chemotherapy is indicated. High dose methotrexate or high dose chemo with stem cell rescue result in a better response rate. So this will give you a little bit of a gist which type of tumor are there, and you can also go through these names and their prognosis, their outcome, and their treatment plan. Now coming to the gliomas, they are the most common. They can be high grade and then can be a low grade or intermediate grade. So incidence is 0.8 per 100,000 children per year, and they can be anaplastic histiocytoma, a very high grade, diffuse intrinsic pontine glioma, that is DIPG, and the glioblastoma multiforme, not very common in a pediatric age group. So HGG or a high grade gliomas have an overall poor prognosis despite intensive therapy. Clinical presentation depending on the site, even then headache, weakness, behavioral changes, or seizure. Extent of surgical resection remain the most important prognostic factor, though now there are few agents which can be used as an adjuvant with the surgical resection as well. Local cell radiation, 5,000 to 6,000 centigrade mainstay of the treatment. Chemotherapy role is not well defined. Combination of CCNU and temozolomide, that is a lomustine and temozolomide concurrent radiotherapy may be more effective. High dose chemotherapy shown a possible small survival benefit, but side effects are too much. And, there is a high toxicity. Pediatric HGG histologically same as adult, but molecularly different entities. So translation of adult clinical data to pediatric essentially impossible. And significance of MGMT methylation in pediatric patient is less conclusive than the adult compared from the adult. Okay. Now this is important. It's a little difficult slide, but it's important. Why? Because now most of the gliomas are actually divided or classified according to their mutation or the molecular marker. For example, IDH wild type has a different prognosis. IDH mutated type has different prognosis. K27 mutated has a different prognosis. G35 mutated has a different prognosis, and the treatment plan as well. So we see the IDH wild type, that location is a hemispheric location is there. Mean is 10 year and prognosis 40 to 44 month. IDH mutated has a better prognosis, mostly frontal lobe and hemispheric. Teen to young adult, more than 5 years. And K27, if you see 4.5 year mean age and 15 months is the prognosis. And H3.3 K27M or H3.3G, these are the number of the mutations, and they are the DIPG pones. So they are the 10 to 24 decimal prognosis, 10 to 24 month only the median survival, overall survival. Now coming to the brainstem gliomas, now classified as a diffuse midline gliomas, and as I said, H3 K27M mutant account for a 10% to 15% of all pediatric CNS tumor. On MRI, DIPGs characteristically expand the bones. You will see the MRI scan as well. Are usually hypointense and typically do not enhance. Histologically high grade and resemble GBMs. Present with the multiple cranial neuropathies. Most commonly 6th and 7th. Nerve palsies, poor prognosis. Median OS is around 9 months. This is the MRI finding. Here you can see the widening of the bones. Actually, it's a very difficult to surgically resect out. Radiotherapy is one of the options to be given, and some adjuvant chemotherapy plus minus. But the prognosis is most of the time is a guarded prognosis. This is a pathway. The same here. You also can use the targeted therapies if you know the pathway of any tumor. For example, allotinib and imatinib. You can see the PTGF and EGF. They can inhibit those pathway and can halt the progression of the tumor. Now, low-grade glioma. So, LGG, most common form of the brain tumor in children. 40% of all CNS tumor in children younger than 18 months. What are the names? So, you can mug up pilocytic astrocytoma, pylomyxoid astrocytoma, oligoastrocytoma, oligodendroglioma, ganglioglioma. So, depending on from where they are coming actually. So, clinical presentation depends on the location. Common location is a cerebellum, other side is diencephalic syndrome may have. Treatment is surgery. First option is surgery if there is a residual disease plus minus chemotherapy, and then if not responding or progressing, RT can also be the one of the option. Now back to the Aditya. So Aditya received the appropriate pre-operative and operative care. He underwent a surgery. His biopsy reveals a low-grade pilocytic astrocytoma in the posterior fossa, which was unable to be resected completely. In Aditya case, even he had residual disease, the brain tumor team or tumor board decided that close observation would be the most appropriate initial management plan, since some low-grade glioma do not regrow even if there is a residual disease. If there was a subsequent recurrence, chemotherapy was planned and as the next recommended treatment. Due to its long-term side effect, radiotherapy was reserved for a tumor that was non-responsive to chemotherapy and was unresectable. So with this, now other gliomas are also there. Visual pathway glioma, they are commoner with the neurofibromatosis type 1. Low-grade astrocytoma tumor involve optic nerve, chiasma, tract and optic radiation, frequent than F1. How about the BRAF fusion, BRAF point mutation? 20%. How about the less frequent molecular aberration? And clinical presentation depend on the tumor location. Isolated finding out combinations of the visual loss, strabismus, nystagmus, or proptosis. Treatment. Chemotherapy first we give, because RT, they are though they may be RT sensitive, but there is a higher chance of developing a secondary malignancy post RT. So first plan is to give the chemotherapy. Vincristine, carboplatin, 40% showed a shrinkage, other 50% showed a stable disease. Bevacizumab and irinotecan can be also tried. Ependyoma, another class of the tumor. So they also come from the neuroepithelial malignancy that occur in the supratentorial brain and even in the posterior fossa and the spinal cord. An increased risk of intramedullary spinal cord ependyoma in patient with NF2. And they present because if you know the site, you can easily make it out. So increased intracranial pressure with headache, vomiting, papilledema, ataxia, multiple cranial nerve palsy, posterior fossa tumor, and focal neurological deficit or seizure if they are supratentorial. WHO classification. So the prior classification was subependyoma, myxopapillary ependyoma, classic ependyoma, anaplastic ependyoma. Now they included one more group, RELA fusion positive ependyoma, and the treatment is a safe surgical resection. Now few papers come up with the adjuvant chemotherapy, but what is established is a safe surgical resection and adjuvant RT directed to the primary site. This is the combination of all histopathology, molecular subgrouping, and the WHO grade and the genetics, and depending on their all of these points, if you taken into the account, you can define their prognosis. For example, if you see the supratentorial third, this one, supratentorial ependyoma, RELA fusion positive, the prognosis is poor if it is WHO grade 2 or 3 and there is a RELA fusion is there. Anaplastic ependyoma is the histopathology, so prognosis is poor. Other than this, they have either intermediate or a intermediate prognosis. So this is dependent on the molecular pathway, histopathology, and the site of the disease. Choroid plexus tumor, this is a rare variant and actually happens very rarely. So very rare, account for only fewer than 1% of all brain tumor and 3%, 4% of pediatric intracranial tumor. It is very important to know that choroid plexus tumor can have a different range of this thing presentation. They can be a well-differentiated benign type. They are called a choroid plexus papilloma, WHO grade 1. Atypical, they are a grade 3. They are highly aggressive choroid plexus carcinoma, WHO grade 3. So if you see the atypical CPPs, they are grade 2, sorry, and then CPCA carcinoma, they are the grade 3. So treatment for CPP means they're benign one. So we know that choroid plexus papilloma surgery alone. If you have a carcinoma, surgery followed by a RT plus multi-agent chemotherapy is the treatment of choice. Germ cell tumor, we come across a few of the patients with the germ cell tumor. The good thing is that sometimes they are a tumor marker secreting cells. So we can do the diagnosis only by seeing the blood reports with blood report and the CSF level of those markers. So most commonly arise in the midline locations such as the pineal or suprasellar region of the brain. WHO classification, germinoma most common. Non-germinomatous like embryonal carcinoma, endodermal sinus tumor, Yorkshire tumor, they actually secretes the AFP, alpha fetoprotein, and the HCG. So we will see those levels and brain mass, then you can make the diagnosis of the non-germinomatous GCTs. Yeah, they can be a teratoma, mature and immature, and mixed GCT if different components are there. Now, clinical presentations, pineal gland GCT, how they will? Definitely, there is obstructive hydrocephalus is there. And suprasellar region, hypothalamic pituitary dysfunction along with the visual defect. How will diagnose? HPR is a diagnostic. Tumor marker, highly elevated level of beta HCG or AFP can be diagnosed of choriocarcinoma or Yorkshire tumor respectively and may obviate the need for surgical intervention. Now the diagnosis is this. What is the treatment? They are very radio and chemosensitive germinoma. Germinomas are very chemosensitive. Current practice is the pre-radiation chemotherapy followed by reduced dose radiotherapy. Chemotherapy will reduces the dose of radiotherapy and in the form of a whole ventricle therapy supplemented with the radiotherapy to the local tumor. In 5 years survival is comparable with the craniospinal RT alone. Previous, when they were not using the actual chemotherapy, they have to give the craniospinal RT, and that caused a lot of problem in pediatric age group with hormonal imbalance, with the growth and other issues. So what now they are giving neoadjuvant chemo and followed by the RT. Non-germinomatous multi-agent chemotherapy regime in addition to craniospinal plus local. Now we will revise what we have discussed so far. The subtype and severity of the brain tumors extremely diverse, with gliomas being the most common type in children of all ages and medulloblastoma being the most common malignant tumor. If you know the most common, then definitely go your investigation go in that direction. There are many possible risk factors for the development. We have seen some few examples. For example, neurofibromatosis or other have a higher chance of developing the brain tumors or prior irradiation. A common triad of sign and symptom for brain tumor include headache, nausea and vomiting, and gait imbalance. All signs and symptoms need to be considered within the context of clinical presentation, including a thorough history, detailed physical exam, and neuroimaging. Although variables, surgery, chemotherapy, radiation are a mainstay of the treatment for brain tumor in children, nowadays we have a targeted therapy as well. In some cases, surgery may be the curative alone, where others require a combination chemo and radiotherapy. Now coming back last time with our patient. So now on your pediatric rotation, you request to continue following Adit through his course. Unfortunately, tumor did continue to grow, and it was felt that subsequent surgery put him in unacceptable risk of neurological damage. So his family are preparing for him to start a treatment with chemotherapy, which will last for about 18 months. Alongside the oncologist, you discuss the schedule of treatment and include the possible acute and long-term effect of these therapies with family who give their consent. They are worried about how he will fare in school, his ability to have children in the future, and how this may affect the family unit as a whole. You provide the family with the various resources, including the local and online support groups, and refer them to social worker who work within the pediatric oncology team. They are happy with this, and other treatment plan is initiated. This is the newer WHO classification of the tumor of the central nervous system with the different categories and taking into the histopathology, and now they are taking into the molecular pathway for defining their risk stratification and the prognosis. So this is about the today's presentation. I think little bit I was able to make you clear what is the brain tumors and how we diagnose, how we treat it, and how we prognosticate. If you have any question, your questions are welcome.
तर ते सोमवारी नॅशनल सिक्युरिटी जे लोक येणार आहेत बरं का, ते 6 दिवस इथं राहणार आहेत. खाणं पिणं वगैरे ते म्हणतात आम्हाला एक फायरचा इलेक्ट्रिकलचा एक माणूस आमच्याबरोबर कायम पाहिजे. लुंगारे आणि कोणतरी एक दुसरं एक कोणतरी जोडून द्यायला. एक दिवस कोल्हापूरला राहणार आहेत ते आणि एक दिवस तासगावला. हो नाही झालं सगळं सोय झाली. फक्त त्या दिवशी सकाळी 6:45 वाजता त्यांना स्टेशनवर घ्यायला गाडी पाठवायची. आणि हे ऑफिशियल आहे त्यामुळे काय ते काय नाही म्हणता येत नाही. सांगितलंय सगळं, फक्त होय तुम्ही केले की पण त्याच्यावर फिरायला कोणतरी ठेवायला पाहिजे.
Yes.
So can you please emphasize on the importance of CSF in medulloplasty?
सकाळी ऑक्सिजन
Yes. So upfront it will be a difficult call to do this.
आमची मागणी नसताना का दिलं?
You have a big tumor sitting in a post-processor patient is with the raised ICT, but after resection of the mass,
10 लिटरचा आपला
before
मेल
CSF examination to find out the stage of the disease.
ते सांगितलं
So
म्हटलं
if it is a CSF is involved, their RT plan will going to be changed.
नॉन ऑक्सिजन बेड
With the more extensive RT, then what they are supposed to do if CSF is not involved. Is that okay?
So was the discussion on the CSF examination in medulloblastoma, sir?
So the question was importance of CSF examination in medulloblastoma.
Yeah.
The what I was explaining is like this: before surgery, CSF may not be necessary, and it is actually an unwanted procedure because they come with the hydrocephalus, with the raised ICT, and it is not necessary. But post surgery, when child is planned for the radiotherapy, before radiotherapy, we used to do the CSF examination to do the staging. It is involved, and definitely their RT field is going to increase, and it will change their risk stratification as well.
Fine, sir. After this, we don't have any question. I think we will conclude the session, and in case there is any question, we will take it on the group.
Okay, sure.
Fine, sir. I missed this presentation for my own work, I told you, but like I have seen a couple of slides. They're really good, and I'm waiting to hear this lecture. Thank you, sir, for your time. It was a privilege to have you all on with us, sir. Thank you.
Thank you.